All right, everyone, for section 4 out of 5 here, we're going to circle back a little bit to the diagnostic process for bipolar disorder. I think it's worth, while this is a pharmacology class, it's important to get diagnosis right because diagnosis is going to determine the direction of our medication decisions. And so good treatment follows good diagnosis. So let's talk a little bit about the differential diagnosis of bipolar disorder and give you a bit of a framework to think about this with. So one way we can think about mood disorders is that they exist on a spectrum, and there's different ways of sort of parsing this spectrum, but one of which is to think of classic bipolar 1 disorder, so manic depression, where people get full euphoric mania on one end of the scale, and then on the other end of the scale, thinking about minimally recurrent major depressive disorder. So these are all conditions that have a depression component to them, but on one side we have we can think of this kind of probabilistically that like if you're at the higher you are in this bipolarity index score, and I'll tell you how we calculate that in a minute, the more confident we can be that what we are dealing with is a bipolar disorder. So this kind of goes back to Bayesian probability, that we're always adjusting our predictions based on what we know about the patient. And as that information gathers over time, we can make small adjustments to our prediction. So thinking about this particular bipolar spectrum like this. So at the top, bipolar 1, less obvious bipolar conditions, and then depression at the bottom of the scale. So I want to illustrate this by using a case from my own practice from many years ago now. So this was a 30-year-old woman who was training to be a therapist, and she came in saying that she thought she might have bipolar disorder, which was kind of in the mid 2000s, this was sort of an uncommon presentation, but nevertheless, that's how she presented. And she told me that she had these sort of episodes of depression, low mood, kind of your classic depression, anxiety symptoms that would start and end with no clear reason. So there wasn't a clear response to what she was experiencing, that she was responding to, and that they would last for a couple of weeks at a time. And at the time that I saw her, she was actually doing okay. She started having these depressions when she was about 13. She had another one when she was a young adult, and then had felt sort of largely kind of low-grade depression since around young adulthood. She didn't have any substance use. She had a strong family history of mental illness. Her mother had schizophrenia, and her father had bipolar disorder. And she was kind of apprehensive about medication. So I suggested with her that we go ahead and treat her insomnia if she was open to that. We tried trazodone, didn't really work. I started thinking this is more of a depression presentation, so I started treating her with mirtazapine, which worked for a little while. And then after about 2 or 3 months, it kind of pooped out. And she said, I remember I took paroxetine when I was younger, and that seemed to work. And so I said, okay, well, let's go with what's worked in the past. And so I prescribed that, and she became kind of hypomanic at fairly low doses. And she said, wait a second, this is how I felt in the past. And I thought, okay, this is actually going to prompt kind of a re-diagnosis. And you can kind of see the fingerprints of that in my treatment decisions. So I used lamotrigine next. She got a rash. It was probably benign, but nevertheless, she didn't want to re-challenge that, so we stopped it. And then I eventually put her on lithium, which she stayed on for many years and did very well, saying that her depression would still come and go, but it was shorter in duration and was less intense. So this allows us to kind of take a look at this method that was it was put out by a study called the STEP BD. So this is the systematic treatment program in depression, in bipolar depression, or bipolar disorder rather. This was the same era in the early 2000s that the KD trial came out in schizophrenia, and the STAR-D study came out in depression. So this is an NIMH study based on real life patients trying to improve the treatment of and diagnosis of bipolar disorder. And so this researcher, Gary Sachs, came up with this uh, this sort of scale, and I want you to think of this kind of loosely. I would not, this is not a highly validated scale that has strong psychometrics, but what it does have is it helps you sort of think probabilistically. So the higher we score in these five categories, the more probable a bipolar 1 diagnosis is present. As we talked earlier in the class about Bayesian probability, there's you can never be 100% certain that you have the right diagnosis, but we can get closer to the target. And that's what we're trying to do here. So the first thing we look at is the age of onset. The most probable time for somebody who's going to develop bipolar disorder to develop symptoms is usually in adolescence. So the sort of most classic time to develop this is high school years, 15 to 19, followed by developing it before age 15 or in young adulthood. And then further on down the line, less probabilistically, the older you get. So the older you get, the less likely your mood disorder is to be bipolar. It's not to say it can't happen, but it's less probable. And then we take a look at what does the episode look like when it happens. So clear-cut mania with that sort of euphoric, grandiose picture, that kind of pure mania, is the most probabilistic sign of bipolar disorder in the characteristic category here. And then if we get in that sort of irritable and mixed mania, that certainly has some weighting here. And then things that have less probabilistic value would be things like people getting hypomanic on antidepressants, or um, having recurrent major depression. These are, very, very weak probabilistic indications. And then we take a look at what does the illness look like. So people that have clear-cut bipolar 1 disorder tend to get sick and then they get better. So they'll have mania, the mania will end, and then they'll fully recover. Which is quite remarkable when you see somebody who can be very sick and then be quite well a few weeks later. But that is a sort of a typical course of clear-cut bipolar disorder. And then the less probabilistic and where it sort of starts to merge more towards a recurrent major depression picture is um, when people have these sort of symptoms that drag on between full-on mood episodes, or people that, so this is a sort of a proxy measure here, people that have psychotic features during mood episodes. So, the differential diagnosis here might be bipolar disorder, or it might be major depression with psychotic features. So we would want to look at not just that one symptom, but all of these five categories. And then again, these sort of less predictive areas that, by itself does not predict. Borderline personality disorder is not equivalent to bipolar disorder, but if you had all these other symptoms, you might have both conditions going on. And then how do you respond to treatment? So people that get well relatively quickly shortly after starting a mood stabilizer, again, that is sort of probabilistic for a bipolar disorder. People that take longer to get better, still possible. So we don't dismiss this. And then these sort of less predictive things. So I think people that get worse with antidepressants but don't get manic, or people that just don't respond to antidepressants, which is often the case with people that have kind of latent bipolar disorders. We'll sometimes see a history of many antidepressants being tried and not working. And then we look at family history because this is a heritable disease. So if there is a family member, a first degree family relative, so that's somebody, mom, dad, brother, or sister who has bipolar disorder, clear bipolar disorder, that again adds probabilistic weight to our patient having bipolar disorder. And then looking less probabilistically at these things such as family history of mood disorders or substance use, again, sometimes proxies for undiagnosed bipolar disorder. So let's take a look at how Annie's symptoms fit into this. So we remember that she had this pattern of having at least she's now had at least 3 episodes of depression that is kind of recurrent. It began when she was 13, so that gives her sort of a so both of these are sort of, neither one of them really tells us, yeah, this is probably a bipolar disorder. They have, they sort of hint in that direction, but they don't. There's nothing definitive here. But then we look at family history. Okay, so she's got pretty significant family history because dad has bipolar disorder, so that gives us 20 points here. Then we take a look at how she responded to treatment. So she did get kind of hypomanic on paroxetine, SSRI antidepressant. So that gives a little bit of weight here. And then she did quite well on a classic mood stabilizer. So that, again, is a little more predictive of a bipolar disorder. But even when we add this all up together, we still don't get a slam dunk case. She's still landing kind of in the middle, which honestly is where a lot of patients sort of find themselves. You do get those cases where people are very clearly bipolar 1, and those are kind of hard to miss. But we get a lot of people who are like Annie who kind of fit somewhere in the middle. Now, Annie had anxiety. Is that a separate disorder or is that a symptom of bipolar? And as you can see here, the prevalence of um, anxiety disorders among people with bipolar disorder is much higher than the general population, which would indicate that maybe this is a separate condition or maybe it's a symptom of bipolar illness. Because about 50%, slightly greater than 50% of people with bipolar disorder will report having an anxiety disorder that they meet full criteria for at some point in their lives. So a lot of overlap between anxiety and bipolar disorder. So now we get a lot of people in our clinics, particularly if you're working with mood disorders, particularly if you're working with trauma, where there's going to be this really, they're going to land even lower than where Annie did. So they're going to end up in this sort of lower half of the scale. When this happens, it's less likely to be bipolar, and we need to start thinking about other possible explanations, one of which might be a personality style that's marked by complex trauma. The term complex trauma usually refers to relational trauma. So this is maybe not the sort of classic witnessing violence or harm, but an instability of relationships, an instability of safe attachment in early life. Sometimes this can present as what we would call borderline personality disorder or complex PTSD, or sometimes called disorders of extreme stress, not otherwise specified. So a bunch of different terms haven't really made it into the DSM with the exception of borderline personality disorder. Now, the way that we figure this out is we've got to look at two things. We've got to look at the symptoms that the person is presenting with right now. That's that cross section right there. What are they currently showing up with? But if that's all we look at, we're going to miss these things. So the way that we start to uncover if somebody has problems with relationships is we look at the social history. So we take a longitudinal perspective. You say, tell me about your last couple of relationships. If somebody tells you, I've been married 3 times, well, tell me about your exes. And I'm looking for sort of patterns. Are there similarities between the way those relationships go? I want to also look, and I'm looking at things like, so if I'm still thinking about bipolar disorder, I'm looking at what might happen when the person, say, flies internationally or has a job that causes them to stay up all night, because those are circadian rhythm disruptions, which will often just destabilize people with bipolar disorder. So I'm looking for a pattern here is really what I'm looking for. So we never make a diagnosis from just a single snapshot. That's insufficient information. We need to get the longitudinal perspective. And it becomes clear when we start to look at the sort of overlap of these symptoms, right? So here's your sort of classic bipolar symptoms. We see the energy dysregulation, we see the goal-directed behavior, we see that episodic course. It comes and it goes. Folks with more of a borderline personality structure, it's going to come out more in relational situations. So there may be this fear of abandonment or building people up, and then they kind of come crashing down. And it's going to tend to have more of a chronic course. And then trauma, of course, there's your classic PTSD symptoms. But let's take a look at where these all overlap. People with all three of these conditions can have problems with impulsivity, irritability, mood shifting, dysphoria, anger control issues, sometimes even paranoia, suicidal behavior. So a lot of things can be going on here. And sometimes, a patient can have more than one thing happening. So a therapist I used to work with, diagnostically, I would sometimes when I was earlier in my career, I really wanted it to be one or the other. And he'd say, Andrew, remember a dog can have fleas and ticks, so we can have two problems going on at once. And it's not necessarily one or the other. Now, the problem that this presents for us as pharmacologists is that we have this toolkit that is largely made up of medications. The problem with in people with complex trauma and with borderline personality disorder, there are no medications that really definitively treat those conditions. We can treat symptoms, things like anxiety or mood or insomnia, but we don't really have anything that's going to treat that underlying problem. And so a lot of times what ends up happening is these folks get diagnosed bipolar 2 is commonly what I see, and we throw a lot of medications at them. When really they probably have more of this sort of relational trauma, maybe a borderline personality style, and they have difficulty tolerating distress. And so we throw a lot of meds at them, we throw antipsychotics at them, we throw benzodiazepines, and they generally don't tend to get very much. You don't see a lot of improvement because really, it's the wrong tool for the job. Like you can use a hammer to drive screws, but it's not going to work very well. So the right tool for the job is a screwdriver, and so the right tool for people with these kind of complex trauma personality issues may be more things like DBT, evidence-based PTSD treatments, maybe even taking some of these medications off if they're not actually doing anything. But a lot of times we don't talk about this with patients. And, a lot of this, I think, is internalized stigma that we have as clinicians. We're afraid that our patients are going to get emotionally dysregulated with us if we talk to them about these things. And I found the opposite to be true. If I can present a borderline personality diagnosis as not as a sort of mark of Cain that's going to follow you around for the rest of your life, or this sort of scarlet letter, if you will, um, that really this is an understandable response to unpredictability in childhood, and that we actually have treatments for it. So we have treatments to help people regulate their emotions, tolerate distress, and put those things into become more aware of their emotions and put all that into play with other people. It's called dialectical behavioral therapy, or DBT. So when we're spending a lot of time throwing meds at this problem and not giving people proper treatment, they're not getting the right treatment. And that also is an opportunity cost. That means it's going to go that much longer before they get actual treatment that might help them. So we got to think about, how do we do this? And I've worked with people who are really good at this. And, I will often use that kind of deconstruction of DBT to explain the diagnosis of borderline personality disorder. And I don't really like the term personality disorder. I think it's really pejorative. So I tend to talk about personality style or interpersonal style, because that's really, when I think about personality, I think about it's that space where that border between your inner world and your outer world, where those interface is sometimes kind of bumpy, and people need help with that, and that's where a lot of people's distress can come from. So we want to do this when we're not upset. So if you've just had a difficult conversation with a patient and you're noticing that you're a little dysregulated, that is not the time to make a borderline personality diagnosis. Do not diagnose as retaliation. Um, but honestly, what I have found is that a lot of patients actually feel kind of relieved finding out that not only does this thing have a name, but it also has an explanation and it has a treatment. And so if we can do that well and artfully, I think we can really help our patients. If we're not sure about diagnosis, get the family involved with the patient's permission. A lot of times diagnosis is overlooked when the family is omitted, because a lot of times patients will come to us when they have depression, but they're going to kind of underreport mania, not because they're trying to hide anything, but because there is this kind of recall bias that happens where people forget that they ever felt good. And so when you ask somebody who has depression, have you always felt this way? They'll tell you, yeah, I've always felt this way. Whereas the family is going to remember times when they had mania. And especially if they made sort of poor choices, poor judgment during that time, spent money, had sexual indiscretions, things such as that. You want to do this obviously with the permission of the family, preferably with the patient in the room. Substance use disorder, very common in bipolar disorder, actually has the highest prevalence of substance disorder of any axis 1 condition. So oftentimes we will see bipolar symptoms emerge more strongly when people first stop using, when they go into remission from a substance use disorder. So just keep that in mind here, that many people with bipolar disorder will have substance use disorder. There are some medical conditions that can sort of look like bipolar disorder. Obviously, the most acute ones would be things like drug intoxication or side effects from medications like steroids. Thyroid dysfunction, hyperthyroidism can make people look kind of hypomanic. Um, those are the most common things. So when we wrap up finally, we're going to talk about this thorny question of antidepressants in the treatment of bipolar depression. So stay with me. Thanks.